fine, but not feeling too badly. They're probably feeling a little flutter. They may have syncopal, they may have dizzy spells as well. And they're at increased risk of having blood clots because they're not having an efficient heart rate. This guy down here, this disordered mess, this represents ventricular fibrillation. That's where the ventricles are just quivering and they're not having a productive contraction cycle. So there's nothing you can recognize in that. This is the type of rhythm that you shock. Okay, you shock fibrillation, and you use the defibrillator paddles to temporarily depolarize the whole heart. And then when it starts again, the hope is that the SA node will start functioning properly, and you'll recover that. If it were a flat line, then that would be called asystole, and you don't shock that, right? All you do for asystole is you do chest compressions to keep the blood circulating, to keep them alive, and you push norepinephrine and epinephrine, because those are the sympathetic stimulators of the heart in hopes that that will get it to depolarize and create a new heart rhythm. Okay?
But with both of these B and C, like, could this person be walking around for days, or is this person feeling bad enough that they're in the hospital saying something's wrong?
That kind of like with our story with blood pressure, that's going to depend on the individual. But yes, there are people walking around that have no idea there's anything wrong with their heart with both of these rhythms. Okay, and likewise, there are people that come in and they're having a heart attack and their EKG looks normal. Okay, so yeah, it's just one possibility. So that's the basics of electrocardiogram analysis. Now, it's obviously a bit more complicated than that because there are books about that thick on how to interpret EKG. I have one sitting on my shelf. So if you go into the clinical practice and your nursing preceptors will teach you whatever it is you're supposed to know beyond that. But that's the basics, so that's a good starting point. Any questions? I think that ends everything I want to tell you about heart. Oh, well, a few things about electrolyte imbalances. The main ions that we're going to be concerned with heart function are going to be potassium and calcium. Okay. Calcium, because it has a role to play in both the beginning of a pacemaker potential, the plateau phase of the repolarization, and actually the contractility of the heart, right? Calcium plays a big role in contractility of the heart, where we actually take extracellular calcium into the cells, and that contributes to the troponin reaction, that calcium-induced calcium release concept that we talked about, which is very different than skeletal muscle. So because of that, extracellular calcium levels impact the heart. Generally speaking, if your calcium levels are a little bit higher than normal, your heart rate will be increased and the force of contraction will also be increased. Okay. So that tends to favor heart function a little bit. Not having enough calcium will have the opposite effect. It will slow down heart rate and weaken contraction of the heart. So we call that hyperkalemia, so increased heart rate and contractility, whereas hypokalemia depresses the heart rate. That slows down the heart rate and weakens its force of contraction a bit. Kalemia, that means potassium. The original Latin word for potassium was kalium, so this actually means potassium. Hyperkalemia and hypokalemia. So in hyperkalemia, the problem there is, and I've talked about this before, if you have elevated extracellular potassium, it makes it, I don't know how to phrase that properly. It shifts too much of the potassium back into the heart, and so it doesn't allow the cardiac muscle cells to polarize properly. Okay, so it'll actually depolarize the heart. So twofold excess potassium actually will stop all cardiac activity. That's called a complete heart block. If you want to kill somebody, the easiest way to do it is inject potassium into them, and that'll pretty much do it.
Wouldn't you have to have like a significant amount? Like you couldn't really.
600 millimolar. That's all you need. Okay. Actually, not even that. Three.
It sounded like you said that from experience.
No, I have not. So I don't.
Not in the
show
last
up on
millennium.
CSI or anything like that. No, your normal extracellular potassium levels, if I remember right, is 140 millimolar. Okay, and if you have double that, that'll create a complete heart block. So no. The most likely case you would encounter this would be you've eaten foods very high in potassium, and you're severely dehydrated, okay? And that would make your potassium levels extremely high, okay? It would be, I mean, I don't know, I guess I'm sure you could look it up. If you want to Google it right now, you could probably Google how many bananas would I have to eat to have a heart block, okay? It's probably like 150, okay? So, you know, it's not going to happen naturally, okay? Unless you're eating foods that have potassium in them.
So wouldn't it happen more if your body is like absorbing it or not? I don't know.
Well, yes.
I know what my mind.
Well, all right, so the way it would happen is basically what I described there, is if you're dehydrated, so you don't have enough water in your body to dilute it, and you're intaking, like you said, absorbing potassium from something. So this would happen inadvertently if people were eating foods that were contaminated with potassium.
But there's not like an autoimmune disease that would cause your body to absorb.
Okay, crush injuries to muscles can actually cause this, okay? When you get crushing injuries to the body tissues, you can get abnormally high potassium released into the bloodstream, and that actually can cause heart arrhythmias. It's one of the things that they have to pay attention to. Some of the salts that you buy for de-icing are high in potassium, you know, and that's a potential danger if animals were to get into that, or were to be stored with food that you would ingest. That's probably the most likely thing I could think of getting inadvertent potassium poisoning from. Hypokalemia, on the other hand, not enough potassium, well, that's a problem on the other side, okay? Not enough potassium means that we tend to hyperpolarize the heart, not depolarize it, but hyperpolarize it. If you hyperpolarize electrically excitable tissue, then that means it's going to be harder than normal to start a rhythm. And so that leads to things we call arrhythmias, okay? If this is happening in the SA node, well, other parts of the heart are going to try to take over. Remember, if we slow down the SA node too much, well, the AV node will try to take over, or the bundle of His will try to take over, or even the contractile fibers themselves. So what you can have happen is you start having ectopic foci, and that's just fancy speak for saying action potential starting in the wrong places in the heart. They're called ectopic foci. That is a danger because that can actually cause the heart to tear itself apart. The heart's very muscular, so if this part's trying to contract and that part's trying to contract and they're not doing it synchronized, they'll actually harm each other and they'll start to cause rupturing. Okay? So those are extreme abnormalities. Okay? The most significant thing being really blood calcium levels. This is why your body pays so much attention to your serum calcium levels. Okay? You have two hormone mechanisms to maintain your calcium levels in a proper range. Now you don't have a lot of calcium. It's only about it's like 5 millimolar. Compared to the 130, 140 of potassium. It's only about 5 millimolar. And it's maintained in a very tight range. You remember the two hormones that are involved in calcium homeostasis? That's an end of AMP1. Parathyroid hormone is the major one. And the other one's calcitonin. Okay? Both from the thyroid, right? The parathyroid hormone comes from the backside of the thyroid, which is the parathyroid gland, and then the calcitonin comes from the parafollicular cells of the thyroid, just to remind you. Parathyroid hormone increases bone reabsorption, and when you reabsorb bone, you get calcium, so that drives your calcium levels up, and calcitonin works the other way. It inhibits the action of parathyroid hormone, so those two work together to regulate calcium levels. Plus, parathyroid hormone causes reabsorption of calcium in the kidneys, so again, to drive up calcium levels. My only point mentioning that is that your serum calcium levels are critical. Okay. Calcium oxalate, yeah, calcium oxalate is one of the things that can lead to kidney stone. So if you're eating things usually high in oxalate, which tea and coffee and things like that are fairly high in that, and you couple that with high dairy intake, which is typically high in calcium, that's a perfect storm. That's a good way to make calcium oxalate stones. And the other kicker there is that tea and coffee and stuff like that inhibits the function of ADH, and so you tend to be a little dehydrated also. So like when I was a youth, I grew up on a farm and we had well water that was terrible smelling. It tasted fine, but it had a horrible smell. It had a hydrogen sulfide smell. So I didn't want to drink water. So what I did is I made iced tea all the time. So I drink like a gallon of iced tea a day. You know? I'm also a massive sweater, a huge head sweater. So I probably dehydrated all the time. And I loved ice cream and cheese, right? So I had a really high dairy intake. I was always dehydrated. I was drinking bucket loads of iced tea. So not surprisingly, by the time I was in my late 20s, I formed some pretty good sized kidney stones. You know,
Isn't that just caffeinated tea though?
well, as far as the anti-diuretic effect, yes, or not the diuretic effect, but the oxalate is in all tea and coffee. It's not the caffeine. So I mitigated. I drink a lot more water now. I really only drink tea when I drink iced tea when I go out to like a restaurant, something like that occasionally. Then I cut down on the dairy a little bit. As I had one of those, and it was. So I'll tell you, I've had abdominal adhesions. I've had appendicitis. I've had kidney stones, and I've had gallbladder disease. So of most of the things that you can have in the abdomen, I've had most of them. Gallbladder disease is horrible. That's bad. But as far as sheer pain,
Kidney stones.
a kidney stone, if that had gone on another couple hours, I probably would have jumped off the roof of a building. I mean, that was really horrible. I called the doctor in a pitiful state after puking into the toilet, for hours and hours, and said, "If I just drink a lot of water, might I pass?" The guy's on the other line going, because it's a Saturday night, of course, because that's when all these things always happen. You could just hear him think, "I don't have to go in." Yeah, why don't you try that? Why don't you try that? So I did. I drank as much water as I could keep down in between my throwing up, and eventually I did. I passed it. When that thing, it was the size, it was like a grain of sand. And I looked at that and I thought, that little bastard caused that pain? That was horrible. You'll hear about kidney stones that are that big.
Oh my God.
Now, you're not going to pass a kidney stone that large. In fact, most of the time, kidney stones that are that big are less painful than the little ones because they don't get in and they don't block the urine flow. They impact kidney function and they have to be removed because they're damaging the kidneys. But they are frequently not as painful as the little guys that you pass. But that was miraculous because as soon as that thing was passed, it was like, wow, I feel fine. It was over. Weirdest thing.
It's worse than that.
So the bottom line when it comes to kidney stones is stay hydrated. That's really the number one thing you do to avoid it. It's just simply stay hydrated. There are, I think, 4 or 5 different types of stones. There's calcium oxalate. There's something called sturvite, which I don't remember what that is.
Uric acid.
Uric acid.
Calcium phosphate.
And calcium oxalate, yeah. Yeah, those are the 4. Okay, so let's start peripheral circulation. Got 20 minutes left? What's that? No more anything? You can take it. Uh-oh. Thanks. We're going to start with something that we've already talked about. So this is going to be kind of redundant. We're going to talk about, we're going to talk about the factors that affect flow through the cardiovascular system. And we already kind of mentioned pressure differentials and resistance, so it's really the same thing. We may not get to that. We may just get through the really easy kind of structural stuff, which is good because this will dovetail with what we're going to do in lab coming up on it's Monday, right? Coming up on Wednesday. All right, so we're going to start with the simple stuff: arteries, capillaries, and veins. Okay? So these are all called blood vessels. A vessel is simply a conducting tube, right? And our 3 types of vessels are arteries, capillaries, and veins. Arteries are defined, you guys tell me. How's an artery defined?
Carries blood away from the heart.
Artery away.
A.
Vessel that carries blood away from the heart. Okay. And the veins are vessels that carry blood back. Okay. Capillaries are the thinnest of the vessels, and they are always between arteries and veins. Capillaries are the thinnest of the vessels, and they are always between arteries and veins. We call those capillary beds. Capillary beds.
Arteries carry oxygenated blood.
Most
or
of the time,
oxygen
arteries
rich.
carry oxygenated blood, with one exception, right? Well, with 2 exceptions, but one is the pulmonary circuit, where it's the other way around. Okay.
So veins are veins
Deoxygenated. Veins are deoxygenated most of the time,
Towards the
except for
heart.
in the pulmonary.
except in the pulmonary circuit, right?
And why is it on all the figures